Welcome back to Pompano Beach Fire Rescue. I'm Captain Perrin. In today's segment, we're going to be going over the Pompano Beach Fire Rescue 2019 EMS protocols.
Good afternoon, guys. Frank Algano, Assistant Chief of EMS, ready to do protocol training today. So let me give you a little overview of why we're doing the protocols and why we're changing other protocols and why you're all here today. Instead of our common protocol rollout, this is more significant. This is a big game changer for us. As we're going through our protocols today, I really want you to pay attention to the 4 chapters in the beginning are more significant of the changes of the 12 chapters that are in this protocol book. So we have the first 4 chapters are game changers. They represent mostly of the dramatic changes here. A lot of minor revisions as well, but there's some game changers that Chief Matt Whitten is going to be talking about today. He's going to be running the protocol rollout today in its entirety. I'm simply here to do the introductions about this and why we're here. As we go forward, who's downloaded the app so far? Okay, most of you guys have downloaded the app. It's interactive, it's hyperlinked already. You'll notice that when you're going through the app on your phone, that when you're looking at the bottom of the green marker here as you're going forward, you can get back to your back page here. It's all hyperlinked. You look at certain medications and certain procedures. It's simply easy for you to get back and forth on your iPhone or Android device. They're all hyperlinked on both devices. So getting back to the beginning here. Okay, why are we here? Why are we doing these protocols? What's the difference between this protocol as a game changer versus what we've been doing all along? Well, as I committed to you guys, we were going to do something that was easy and accessible for you to get on your phone, on your laptop's computer. Right now, your current protocols are really tough to find on the S drive, and out in the field, if you're not connected wirelessly, you're really not going to find those. They should be accessible. You know, there's over 600 pages of the Government protocol out there that we're using. This format here is 154 pages with pictures and hyperlinks, so it's easy for you to swim through, and it includes the adult and the pediatric protocol information on the same page. So it's a concise protocol. It's what you've been wanting for a long time. I mentioned to you guys this is what we're going to be doing. So here's your product arrival. We're filming this for the other classes to see, so we have all consistency of delivery of what we're doing today. So what we're concerned about is protecting the citizens and their health, and our practitioners giving EMS care for our citizens that's progressive, good science, and well-researched. That's what these protocols represent. There's a lot of different movements out there right now in Broward County. There's a lot of different departments doing different protocol things, and it could be very easy to get trapped into looking at somebody else's doing work out there that's not really evidence-based science based on American Heart Principles or other well-researched abstracts out there. So what we're focusing on is all the science that you see here is based on the American Heart Association guidelines, well-researched and published studies that are not theoretical, they're actually based in science and have been replicated for the same outcomes and conclusions. So all the things that you see here are defensible in court and with what you and your patient care, okay? So that's why we're doing these protocols. That's why it's a game changer. We partner with Broward Sheriff's Office because they've done a great job on their app, and their medical director, Dr. Jim Roach, I give a lot of credit to for authoring a majority of these protocols. We had Dr. Farrell, myself, BC Whitten, and Freddie Sampson come along with other protocol committee members developing this protocol for you so that it's easy to be accessible on any device that you have. It's electronic 24/7 in case you're in that 2 o'clock in the morning call and you're trying to find out, oh, I got to get this right step. I want to make sure I include this medicine or this procedure. What was that? Okay, so you can look at it real quick. All these numbers, the Florida poison control numbers in here is hyperlinked. Everything's wonderful. There's a lot of reference material that BSO has put into their app, and we're simply sharing their space. So they've got the app. They're more than congenial to let us come into their app world and let us put our protocol into there. So when you're seeing our protocols, ours really mirror images their protocols quite a bit. Their protocols that are differences, probably 95% is the same, but the protocol difference would be the blood products, transfusion protocols. The airway protocols would be RSI and etomidate. We're not adopting those yet. We need more training behind advanced airway classes, and then we can go to RSI and use etomidate. We're probably one drug right now away from our inventory in our drug box of using etomidate. So we're not there yet. We got to do some more training. We don't have a lot of advanced area cases that would require that, so we're not so hasty about having to do that right away. We're not doing vaccinations. We're not giving antibiotics or inoculations out there in the field. That seems to be a community paramedic movement that's happening out there. We don't need to do that in our community. We have 5-minute transports in a lot of cases, and our patients wouldn't require that kind of practice anyway as an EMS practitioner. So, and going back here, I'll go back to a couple of slides. Let me get the general information here. Go back. Okay, whoops. Go back
Click
to the
the
beginning.
second button down on your remote.
Okay, so our medical directors that helped write this, obviously, is Dr. Michael Farrell, and also Dr. Roach and Dr. Paley had a lot of input on creating these protocols today that you see. So we got the team of really sharp people with, again, with BC Witten and Freddie Sampson helping in the trauma part of the protocols. And we got to give that credit to BSO for really helping out quite a bit and giving us this product to work in and swim into. Any questions for this before we get on to the next page? So let's continue on with our protocol training today. We're shooting this thing so you can access this on Target Solutions. You already know how to use the app, going back and forth. BC Witten will get here and he'll talk to you about what the red highlights of the protocols mean. And we're ready to go. Any other questions? Anything else? Nothing? Good? All right. Thanks, guys.
Okay, so let's get started. So the first section's the general information. So throughout the protocol, you'll reference back to this periodically. So this is more general. When I go over each slide, I'm going to just cover what I feel like is a change or important topic. I'll pause slightly before I forward, so if there's any questions, please ask, because no two classes is the same, so it often depends what kind of questions we have. So that's why we're here, so please ask questions if we have any. So this slide, this is an important slide. I don't know if you heard people talking about it. The intent of this slide, there is no way you could create a protocol to cover every scenario. So this is not meant to be strictly followed. We want to be able to have the medic to be able to think and change the treatment plan if the scenario you're faced with doesn't exactly fit one of the protocols. When we go through, we'll actually talk about some examples where it might be a good idea to use this. So basically what it's saying is 2 medics, if they agree, have the authority to deviate from the protocol. So obviously the intent of this is not to say, I don't have a protocol, I can do whatever I want. This would be the exception to the rule. But if you in good faith decided, I feel like this is better for the patient, this gives you the authority and the coverage to be able to do that. Understand? Perfect. Okay, so medical administration. The one that sticks out to me the most is the IO. So you notice now we talk about the order of preference. The humerus is number 1. So we're very comfortable using the tibia for the IO, but now we know, particularly if someone's a diabetic or has some vascular disease, very high chance for infection. We know we've had a couple of cases in Pompano where the person had a bone infection. We think because of the IO and it put them in hospital for a little bit. Not to say you couldn't do it. A lot of the stuff we do is a risk benefit, but we know now because the blood supply is much better at the humerus, very little chance of infection. So that's why, one of the reasons why we're going to be going to the humerus. So we don't have enough time to do that training, so we know we're not going to cover everything. We're going to have to do some more intense training on certain topics. That's one of them. So there's discussion where exactly you would go on the humerus. We're going to straighten all that out and do some specific training on that. If you notice the pediatric, we're still using the tibia, but these are basically written in the order of preference. So you can still use all those sites if you feel like it's appropriate. For the needles, we're trying to make it simple. So we'll get on the same page of logistics, so we should just have basically 2 needles to choose from. A 23 gauge for the infants and small children, 21 gauge for larger children and adults. So it should help that. You notice we still have the MAD device, so you can still give the drugs intranasally, but you'll see it's probably rare that we would actually use that route now. Okay, this is a big page for us. So throughout the protocol, you're going to hear us talking about push dose epi. And we use the term so much, it's real important you understand exactly what push dose epi is. So if I was to just grab the box of epi we're used to, what concentration is this? 1 to 10,000, exactly. We're looking to get to 1 in 100,000. So there's a couple different ways you could accomplish that. One would be you could push 9 mLs of epinephrine out, draw back up 9, you would have your 1 to 1,000. That wastes the epi, but you could do it. What we feel like the better way to do is how many mLs are in my saline syringe? 10. So I would push out 1 mL of saline. You could use the 3-way stopcock, hook both syringes up, and what I'm doing is I'm pushing 1 mL of epi into my saline. So now I have 10 cc's in my syringe, 9 cc's of saline, 1 cc of epinephrine. This is my epi 1 to 100,000. So when we talk about it through the protocol, this is what we're talking about. So I don't care the age of the patient, I don't care the weight of the patient, it's the same administration. The reason we separate it between adult and pediatric is because of the endpoints where you would stop administering it. And that's the blood pressure. That's the only reason. Everything else is the same. You push 1 mL every 30 seconds until you get your endpoint. So for the adult, it would be a systolic of 100. For the pediatric, we'll talk about that in a second. All right, is that clear about what epi 100,000 is? Okay. So you see there are additional medications listed. These are ones that need to be diluted. If you look at your medication sheet, I believe it's on page 149. We have one of the medication sheets. 147. If you notice, some of the medications are in red. That means they need to be diluted. So on your medication sheet, thank you. So on your medication sheet, if the medication is in red, that means they need to be diluted. You'll notice in the protocol, some areas are red. That just means that needs special attention. Maybe there's a little emphasis that needs to be put on it. It's something different, something new. But on the medication sheet, red means it needs to be diluted. So these 3 is for pediatrics. Ketamine, you would dilute for the adults, and we'll go over that as we go through. With the drugs, we're differentiating the term infusion and drip. Now in reality, those terms are interchangeable, but I'm using those just so you understand there's a difference. An infusion is something that you administer over a definitive amount of time. So for the adult, it's going to be 10 minutes for both. For one pediatric infusion, 25 minutes, but everything else for the whole protocol would be over 10 minutes. So if I was to use the drug, so if I was giving amiodarone, once I put the drug into the 50 ml bag, now my issue is how do I get that 50 ml bag into my patient in 10 minutes? And it's the same every time. I'm going to use a 10-drop set, 1 drop a second, and that will give the whole bag in over to 10 minutes. So I really, once I get the drug into the bag, I'm not concerned with the drug. In reality, I'm concerned now with the drip rate. So that's an infusion. Then you have what we would term a drip, meaning in theory that could be run forever. So dopamine would be an example, Levophed. We got rid of all the drips. So now, whenever you, in the old protocols, you would say, I would use dopamine or Levophed, we're now going to use the push dose epi. And again, the dose never changes. I don't care age, weight, it's always 1 ml every 30 seconds until you get that desired blood pressure. Okay? So this screen, the incapacitated person law, why do we put this on all of our protocols? Why is it important?
Someone has the right to refuse care.
Right. So we always talk about these gray areas. Well, the person had, I'm pretty sure he had been drinking, he had a medical emergency, his vital signs were altered, and there's always a gray area of, well, can I take him, can I not take him? A good way to think of this protects us from even the thought of, well, we can't take this person. If you in good faith believe they're having a medical issue, they're intoxicated, this gives us the right, the legal authority to take them to the hospital. So that takes away, hopefully takes away any concern of saying we're kidnapping someone. But in reality, when we're there on scene and someone says, I'm absolutely not going, now it comes down to, do I forcefully put him on a stretcher? We're not saying we're going to start putting our hands and putting people forcefully on the stretcher. So down below, we would never advocate someone using unreasonable force. So if you were faced in those scenarios, you want to, at the end of the day, be able to say through your actions and your written report that you made every reasonable attempt to get that person to go. So that might include getting family members involved, calling BSO to the scene. So when that final decision happens, if BSO says, look, we're not willing to take the person forcefully, you may decide we're not taking the person. But make sure you're documenting that it's very clear that you made every reasonable attempt to transport the person. All right, is that clear? So patient assessment we left on there. Most of us know how to do a good report. This is really there to give you an idea of what a thorough report would be. A lot of the language we chose was very intentional. So you'll notice on a lot of the pages, we didn't put shall or must. We use words like should or could or consider. So depending on the report, the patient, this would be examples of what would make a good report. So when we look at a report during the QA process, what we're basically asking is an idea of what you walked into, what you were observing, what the patient told you, the assessment, your plan, basically what you did, and the one area that I feel like we can improve in is how we left the patient. So if you had an overdose and you gave Narcan, you did perfect treatment, and you documented, and we transported the patient to Imperial Point, and then the report ends. Well, we need to know, well, how was the patient in the end? So it doesn't have to be real elaborate. It could be something as easy as, upon transfer, report was given to RN Nick, patient alert-oriented ×3. That paints a very clear picture. So doesn't mean it's elaborate, but try to paint that picture so there's no question that we provided great care. This page, again, some general information, but a couple areas that are worth mentioning for an unresponsive adult. We're bagging the patient. It talks about if after 2 minutes you're still bagging and need to support that airway, you're going to advance using a more advanced airway, so either an I-gel or an ET tube. So does that have to be a very literal meaning of that? And what I mean by that is, say you had that same overdose patient and you gave Narcan and you noticed, oh, we're past 2 minutes bagging this person. Is the intent of this protocol that, yep, we have to intubate them? No, that's not the intent of this. Because in that case, you reasonably foresee that that patient's going to come around. So that's not the intent of this protocol. This is designed for the patient you're bagging, and after 2 minutes, there's no reasonable, foreseeable reason why the patient's going to start breathing again. That's the patient we would really want to consider upgrading the airway. If you do, you can use an ET tube or an iGel. We're no longer saying you have to use one or the other, except if it's a cardiac arrest. In that case, we're going to go with iGel first, and the main reason of that is no one can intubate faster than you can place an iGel. So we'll get it going with that, and you'll see, depending on which of the algorithm sides we go down, you may not even ventilate the patient, but we'll go over that later. So that would be the only exception. If you decide you want to intubate and you have 2 failed attempts, then we're asking you to use the iGel. All right, any questions on this one? The pediatric. What is the preferred method of ventilating? The bag mask. So we put that in there because we don't want you to feel like you have to intubate them, you have to use the iGel. So particularly for the pediatric, if you're ventilating well, so you have a SAT above 95, 99, do you have to intubate that patient? No. But what if you know the hospital's going to intubate them when you get there? Shouldn't we intubate them? Don't confuse pre-hospital with the hospital. Even if you in your mind know that patient's going to get intubated at the hospital, our job is to get a viable patient to the ER. So if I'm bagging perfectly well, don't stop what you're doing to try to establish an ET tube because you think that looks more advanced. So we're not going to do things for our ego. We're going to do things because they make sense for the patient. So if you're bagging effectively, leave it alone. I always try to tell people, before you do something, ask yourself, what am I trying to fix? If the answer is nothing, then maybe you don't need to do it, and that's okay. And then it talks about if you have to use the advanced airway, then again, the iGel or ET tube. Okay, this talks about oxygenation. So we've for a while now talked about you don't have to give oxygen. Oxygen may be bad even if the person has a normal pulse ox. So say we show up and John's having chest pain and he's got a SAT of 99 and I put oxygen on him. Well, we now know oxygen is actually a vasoconstrictor. So if he's having an MI, me putting oxygen might have actually made his MI worse. So we don't want to give oxygen unless they need it. Now with that being said, if you think he's having trouble breathing, he's telling you he's having trouble breathing, we're going to give oxygen to the patient. So don't overthink this one too much. There are 2 cases that you would definitely give oxygen no matter the pulse ox, and that's the traumatic brain injury and someone 3rd trimester pregnancy. Worst thing we could do for those 2 in particular is withhold oxygen, so we're going to give oxygen no matter what in those. So that would be our 2 exceptions. The ventilation rates, make sure you're realizing when you're reading it, one of them says with a pulse and one of them says without. So with a pulse, we're all used to rescue breathing, 1 breath every 5 to 6 seconds. We made it a little simpler, just using 1 every 6 seconds. But without a pulse, now we're ventilating 1 breath every 10 seconds. So that is a change. So just make sure you're realizing 1 rate is with a pulse, 1 rate is without. Okay, this section, it talks more of, if you notice the language of should, these are patients where you should be considering using the capnography. Suggestions where you should be considering using the ECG. And when we get to the vital signs, we talk about things you should do, and one example would be the temperature. So if you think it's appropriate, so you're trying to rule out a sepsis patient, fever, that's why the language says temperature as appropriate. And then with the blood pressure, how many people take a manual blood pressure on every patient, the first blood pressure, right? The monitors now are very sophisticated, they're very accurate, so we wrote it to what we actually do. So you can take a blood pressure with the automatic cuff, but if you suspect there might be a problem or it's very abnormal, then we're asking we confirm it with a manual blood pressure. Okay? We've been using this age for a long time, but there was a lot of discussion and controversy throughout the county with the ages, specifically the age for a trauma patient. So you notice for the medical patient, under 18 is considered a child. For the trauma patient, the age is 15 and under is the child, 16 is an adult. So if we had a patient meeting trauma alert criteria and they were 16, where would we take them? Exactly. If they were 15, where would we take them? Broward Health or Memorial, exactly. Okay, is that clear? So this screen we put on just some general guidelines of what a normal vital signs would be. The one I would tell you to just make sure you're taking note of is the blood pressure for the child. So when we talked about using the push dose epi, we said the endpoint was the blood pressure. Well, depending on the age, that is going to be different. So a good one to remember is the 70 plus 2 times the age. So is that the ideal blood pressure for a pediatric? No, correct, it is not. But what that is, that's the 5th percentile. So basically that's the lowest blood pressure that we would be saying that that patient is compensating. Anything lower, they're hypotensive. So when we're using that push dose epi, you want to keep giving it until you're at very least that 5th percentile or 70th plus 2 times the age. So that's a good number to remember. Okay, this part brings up a lot of controversy or discussion, how you want to look at it. Priority 1 patient is a cardiac arrest or a respiratory arrest. So you'll see later on, we're going to differentiate our cardiac arrest into a primary arrest. We're saying we think it's cardiac in nature, or a secondary arrest. We think it's respiratory in nature. So if we think it's primary in nature, we're now going to bring our patient to a STEMI facility. So the question has been asked frequently. I walk into a nursing home, 90-year-old, unknown history. The staff isn't very familiar with the patient. They don't really know what is that patient, a primary or secondary arrest? A primary, exactly. If you know that they were a drowning victim, if you know they were choking before they went into cardiac arrest, those are examples that you would use the secondary algorithm. But for adults, as a general rule, they're going to be a primary arrest. So if we have a primary arrest, and now we're saying we have to take them to a STEMI facility, where would we take them? Or let's make it easier. Where would you not take them in our catch of hospitals? Right, so as of today, we just wouldn't be able to go to Imperial Point. Now, keep in mind, they have a cath lab. They're working on becoming a STEMI facility. But as of today, they don't meet our criteria of being able to bring a STEMI alert to them. Hopefully, very soon, we will be able to, and it'll make it a lot easier. But as of today, we're not able to do that. Okay, is that clear? So where would we go? Yeah, North Broward, Holy Cross, Northwest, exactly. Good, okay. A priority 2 patient, unstable. Priority 3, very stable. We've been using very similar terminology all along. Is real consistent of what those mean. So now we're talking only about pediatric patients. So if you're working a pediatric cardiac arrest and you get ROSC. So what is ROSC? Yeah, so you get a pulse return. If you get ROSC, where am I going to go? To a comprehensive pediatric facility. So the next sensible question is, well, what is a comprehensive pediatric facility? It is a facility that has pediatric admitting, surgical options, and a PICU. So right now, we're going to say that Broward Health or Memorial are your comprehensives. So people were asking, well, what about Northwest? Northwest does admit pediatrics, and they're a great option to bring pediatrics. But when we talk about comprehensive centers, as of today, they would not be considered a comprehensive. Okay, and we'll talk about pediatric, whether they admit or not in a second. So with a pulse return, we're going to the comprehensive. If they don't have a pulse return, so we're still working the code, where would they go? Closest appropriate. But what does that mean? That means they'd go to the closest pediatric facility. So who's not a pediatric facility? Okay, so when you talk about this, we need to look at our hospital matrix. So on the app, there's a hospital matrix. So when you look at it, it lists the hospitals that are pediatric and then ones that admit. So when we're talking about a critical pediatric patient and we say which is the appropriate facility, we're talking about a pediatric hospital. We're not concerned whether they admit the patient at this point. So who would not be?
No one.
No one, exactly. Every hospital in our area is designated as a pediatric hospital. So you could go to the closest facility with that patient. So the topic always comes up, well, they don't admit. Well, Broward Health and Memorial are set up in the very similar ways. It's much more cost effective to have one central hospital that admits. They have outlying hospitals that filter the patients in. That's the way the systems are set up. So there was long discussion about what's better to do for the patient. Do we bypass hospitals to go to a comprehensive, or do we go to the closest hospital, make sure the patient's stable, and then allow them to transfer? All the medical directors agree the only option for us is to go to the closest appropriate. There was a lot of discussion on it. And so if that question ever comes up, we would not bypass hospitals to go to a comprehensive. You would go to the closest appropriate pediatric facility. And we're fortunate that all of those meet that criteria for us. Okay, is there any questions on that? Good? Okay. Priority 2 patients, closest appropriate hospital. Priority 3, meaning a low acuity. We left in there the freestanding emergency rooms. We don't have any in our area right now. The closest one that I know of is Boca West. Unless someone specifically asks for you to go there, we don't advocate making that an option. Even the areas that have those, the problem you come into is if they have to be transferred or not. So the general consensus is yes, if they're adamantly asking to go to that center, it could be an option if you get permission from the battalion, but as a general rule, we're going to transport to emergency department. Okay, trauma patients. We try to take out all the guesswork in this protocol. So one of the questions that always used to come up was, what if a patient's over 20 weeks pregnant and they meet trauma alert criteria? Now this one you could argue either way. You could argue go to the closest trauma center, save the mom, save the baby, go to the OB center, save the baby. The best option that the medical directors decided was to go to a trauma OB facility. So where does that mean? You're right, so Broward Health or Memorial, right, okay? So it takes the guesswork out of that. STEMI alerts, we'll talk later about what constitutes a STEMI alert. It changed a little bit. And stroke alerts. Where do we transport stroke alerts? Not a hospital. What category? Primary or comprehensive? Exactly. So comprehensive. In Broward County, we only transport stroke patients to comprehensive. You have a longer window or a wider window, and they have more options for treatments. So if you had a stroke, what would be the hospitals at this point you could not transport to? Imperial would be one currently.
Northwest.
And Northwest, exactly. A lot of people don't know Northwest is only a primary at this time. I believe they're working on becoming comprehensive, but at this point, we would not go to Imperial or Northwest, exactly. So we have plenty of options. Any questions on that? We good? Okay. We talked about pediatric strokes at length. And again, there was a lot of variation of which hospital had coverage, so the decision was made, if it's a pediatric stroke, they go to Broward Health or Memorial. That way, the patients get consistent care. It doesn't depend on the day. For OB, we already talked about if they meet trauma alert criteria, but what if it's just a medical code, a medical cardiac arrest? Where do we go? Again, you could argue it both ways. And we decided the best option for both the mother and the baby was to go to an OB hospital. So what would be the two closest OB hospitals we have? Holy Cross and Northwest, exactly. All right, any questions? We try to take all the guesswork out. Now, if there's some reason why you feel you need to go to a different hospital, that might be a good time to utilize that two medics agree. You justify why. If you're doing it with good faith, that would be an appropriate reason. Because I'm sure we could all come up with examples when we might want to consider deviating. Okay, so for this, decompression and carbon monoxide, the key point is you want to go somewhere with a helipad. We're not going to get involved into which chambers open, which one's available, which one's not. We're going to bring the patient to a hospital with a helipad, and that hospital will find out the appropriate facility. So most likely for us, which hospital would we take the patient to? North Broward, exactly. Now when we talk about psychiatric patients, where do we take psychiatric patients? IPH. And why do you say IPH?
Because they have a appropriate psych facility.
Right, so they are a psych facility, but we take them there because it works well for us. We have a good relationship with them. BSO has a nice handoff. So if that works, I'm not saying don't go there, but just be aware when we transport a psychiatric patient, we are transporting them for medical clearance. End of story. So in reality, we could go to any emergency room. They get medically cleared, and then they get transferred to the appropriate psychiatric facility. So if it happens to work out that everyone wants to go to Imperial Point, that's perfect. But don't feel like you're obligated to it. If there's some reason why you feel it's in the patient's best interest to go to a closer facility, you absolutely can. Now in the old Northridge, they moved Florida Hospital there, which is a very nice psychiatric hospital that does pediatrics, adults. What if one of the BSO officers says, let's just transport him right there? Could we do that?
You have to get advance orders from the battalion chief, I would assume.
What do you think? Even if the battalion said, yeah, go ahead. This is a newer thing, so we're all learning this. The answer is no. And the reason is they have no capability of medically clearing them. So even if we did, they would say, you know, we'd love to have the patient, but you have to go to the emergency room and get him medically cleared. Okay, is that clear?
Yes.
All right. We put some language for the helicopter. BSO, they now have a separate helicopter for EMS and police. So it was supposed to have gone on board last month. I believe it may have gone on board yesterday or today. So we're going to have a lot of more options. They're actually going to come to the department and talk to us specifics. But the only thing I will tell you is the weight is a big factor. So if we are requesting the helicopter, you're going to want to know the weight of the patient. And depending on how many crew they have, how much fuel they have on board, will determine whether they can take the patient or not. And they'll go over what they can handle and what they can't. But they're excited about having the separation, and the medics are now going to be carrying blood, like Chief Galgano mentioned, so I think we're going to probably start utilizing them quite a bit more. All right, that concludes the general information section. Any questions on that section? Okay, let's take a 5-minute break. Okay, so now we're going to be starting the medical emergencies. So when you go into the real app and when we say it's all hyperlinked, when you get to the section, if you touch the different sections, it'll take you right to that section. So you wouldn't have to go through each section to find, say, dehydration. So let's start with allergic reactions. So we treat allergic reactions right now. So we'll just hit really the differences of how this one's set up. So we're actually going to change the language a little bit on this one because right now it talks about moderate and severe. And the concern is that if you say moderate, do you think, well, the patient's not that serious? In both cases, the patient may be having respiratory issues, the tongue may be swelling, throat may be swelling. In either case, we're going to give our epinephrine. The decision really is what route. So what's going to determine that is the blood pressure. So we use the blood pressure of 100. How can I, without taking an actual blood pressure on the arm, determine whether someone has inadequate blood pressure or not to be able to use the IM route?
Pulse.
Exactly. Pulse, but more specifically, do they have a radial pulse? So if I'm talking to you, you know I'm alive. But if I don't have a radial pulse, but I have a carotid pulse, that's a great indication that my blood pressure is significantly low, probably 70 or 80, maybe up to 90. Will IM work? Probably not great. So a better route would be to go IV or IO in the humerus. So if we're going to go that route, again, we're using our push dose epi, so 1 ml every 30 seconds until we get that desired blood pressure effect. So when you look at this protocol, for a mild reaction, so just a little bit of rash, are we going to stick the patient with epi? No, just like we've always been doing. So depends on the symptoms. You take parts of the protocol that you think are appropriate, but don't worry about giving epinephrine. If you think they start complaining of airway issues and you're starting to think, maybe I should give them the epinephrine, give them the epinephrine. That is a life-saving drug, particularly in this case. All right, we clear on that? For the pediatric, same sort of idea. The difference between which route we're going to give the epinephrine would be the blood pressure again. So unless there's a specific question, I'm going to keep going. All right, altered mental. This screen is just an idea, a reminder of things to consider if you have a patient with altered mental status. The diabetes was one of those examples. So if you knew you had a patient, blood sugar was below 60, what are we giving them now? The D10. We've been carrying it for a little while. How are we giving it? Are we dripping it slowly in, or are we giving it fast? So the way to think about it is you're going to be giving it 100 mLs at a time as fast as you can. You push your 100 mLs in, that should fix the hypoglycemia. Recheck the blood sugar. Push another 100 mLs if it didn't work, check the blood sugar. Chances are that has fixed the problem for sure. So the idea is not to drip it in slowly, it's to push that D10 in pretty quickly as you can for 100 mLs at a time. All right? When we talk about, okay, you had a patient, they were altered, they were unconscious, now we gave the D10 and now they're alert and oriented. And we've all faced the patient and said, look, I feel better, I don't want to go now. So what do? We discussed that earlier and talking about, well, can you force the patient, can you not? So just one thing to be aware of, if someone takes oral diabetes medications, they're at a much higher risk of going back into that hypoglycemia. So that patient you would absolutely want to take to the hospital. If they refuse and you've tried everything you reasonably could, you want to try to make sure and document that someone was in the house, they had food, they've been eating, and make sure that you're setting them up to not go back into hypoglycemia. The glucagon's still an option, IM. So we haven't been using it that much, but we're keeping it in for this case. And also you'll see for beta blocker overdose, it would be the appropriate treatment. For the pediatric, we're using the D10 as well, 5 milliliters per kilogram. And same idea, you're going to be pushing it in quickly, retesting the sugar, and repeating as needed. All right, dystonic reaction. So this patient probably is on psych medications. They have that reaction. They may have the face that's stuck in a certain position. We've treated this in the past and we've written it up more as an allergic reaction to the medication. All we did was make a new protocol to call it what it really was. So the treatment hasn't changed, the Benadryl, but it just explains it a little bit better than we had it. Okay, so fluid. The language on the fluid is going to be the same throughout the protocol now. So for the adult, 1 liter, recheck lung sounds every 500 mLs. For the pediatric, 20 mLs per key, can repeat twice. So it should be consistent throughout. If it's not, let us know and we'll make sure it's consistent. Okay, hyperkalemia. What is hyperkalemia? Travis, that's true. High potassium, perfect. So high potassium. What patient would be realistic that we would even know they had high potassium?
IT waves.
Right. So you could use the EKG and be a good indicator, but if you knew the person was a dialysis patient and either hadn't had it yet, missed an appointment, we even had a case where the person was unresponsive in front of the dialysis center. So that's a good indication that this is a possibility. So if someone's mildly hyperkalemic, you're going to start seeing those P waves, those spike T waves like Matt was talking about. When we really get concerned is when the QRS starts widening and the QT interval starts widening. That's when it becomes very dangerous. So as a general rule, if we knew they were hyperkalemic, we would start giving our treatment. So if you had to pick one drug, if I said, what's the treatment for hyperkalemia, what would it be? Calcium, exactly. So you have one, you can only get one IV at the time, and there's always that discussion, well, do I give the bicarb first, the calcium first? Think of it as calcium chloride is the treatment for it. That's what's stabilizing that cell, and everything else is a bonus. If you think of it like that, it makes it a little easier if you're faced with that. So we give the calcium chloride, and why am I giving the albuterol? Are they having bronchoconstriction? That's not why we're giving them. That's helping the potassium push back into the cell. So we give the albuterol, we give the bicarb to help the potassium go in. In the hospital, you may even see them giving dextrose and insulin, all helping the potassium push back into the cell. So in a later slide, we'll talk about, well, if you suspect that they're hyperkalemic, there's one drug we definitely wouldn't give them. Does anyone know what it is? All right, we'll keep you under suspense so you're excited for that slide. So we'll talk about that in a second. All right, so just remember that sine wave when we talk about that. So nausea, vomiting, we kept the language for the Zofran the same throughout. So you'll notice for the adult, we have 4 milligrams, and it's IM, IV, IO, and then we're keeping our ODT. So what is ODT? That's right, orally dissolving tablet. So we're keeping that. So if the person is able to take it orally, that ODT is still appropriate. You'll notice for the pediatrics, it says IMPO, but we also have ODT. That's actually a different route. So if they're over 4, you could consider giving ODT. But if they're younger, we don't want to give ODT, but this gives us the option to still give it PO. So just one example, but you have a 2-year-old. We're vomiting, you decide I want to give Zofran, the mom or dad says I don't want any IVs, and you're not giving them a shot. Well, ODT wouldn't be the option, wouldn't be the best choice because they're under 4. We could use PO. So what exactly does that mean? If you read down, we can use the IV formulation of Zofran, PO. So you would draw it up, but instead of giving it IV, we would squirt in the mouth, and it works as well. So it just gives us one more option out there. So respiratory distress, this is more of a general screen. It talks about conditions in general. Then it goes into specific conditions. So COPD, the patient's had a chronic condition. You would anticipate the high CO2 levels, maybe a lower SpO2 levels. In those patients, we'd be going with the albuterol and the solumedrol. Those patients have the issue with their alveoli, and it's a chronic condition. we run a lot of asthma calls. So now we want to think of the asthma in two bundles. So the first bundle is the typical patient, the patient we're used to. So when you have asthma, you have the bronchoconstriction, the inflammation, increased mucus production. We're giving the albuterol for the bronchoconstriction, the thiamidrol for the inflammation. You notice there's no Atrovent anymore. So we've taken Atrovent out. It's a longer acting. We feel that the albuterol is great for our purpose, and there's no limit anymore. You can give it as needed. If this first bundle doesn't work, that's when we would go to our second bundle. So in the asthma and the COPD, you notice there's CPAP. So CPAP may help in both those cases. But if you're going to go that route or try that, make sure you're watching your patient. There is a chance the CPAP could make them worse. So if you did a trial of CPAP and they started getting worse, you would discontinue it, take it off them. So if the initial bundle didn't work, our other options would be epi or mag. So those have always been our options, and we discussed, well, which one is better. We put epi before mag for the simple reason it's quicker to give. So the mag, how would we administer the mag? Yeah, so you remember from page 10, we were putting the 2 grams in a 50 bag, running it 1 drop a second with a 10 drop set, and it takes 10 minutes versus giving the IM immediately. This could be another example where the 2 medics decide, you know what, for some reason I want to give the mag before the epi, it's acceptable. But we wrote it as try the epi. If that doesn't work, you're going to repeat the epi and give the mag at the same time.
So these are written in sequential order then?
Yes, but again, if you feel for some reason you would rather give the mag first and you can justify it, that might be a good example. So don't think of it as you have to always use the epi first. Pediatrics, same idea. The first bundle is your usual patient. We would anticipate that'll fix most of them. If it doesn't, then we would go to our second bundle. Now we're getting into the croup. So if you have a patient, low-grade fever, they look sick, but not too sick, like more of a viral illness. They have a stridor, barky cough. Now we're describing a croup patient. We're going to give 0.3 of 1 to 1,000 epi, and we're going to give it nebulizer. So we even wrote, yes, 3 mLs, because people often question, that's a lot, but you're giving it through the nebulizer. You're not doing it through the IV. So that's a nebulized dose. We included epiglottitis into it now. So if you find a kid high fever, look very sick, they're tripoding, they're drooling, what does that patient possibly have? The epiglottitis. That can be very dangerous. So what is the key to know with epiglottitis? Exactly. So in that patient, our priority is to keep them calm. So if you're able to give the nebulized epi, do it. But don't risk agitating them. So our priority is keeping them calm and getting them to the emergency room. So even when that patient's in the emergency room, they're most likely going to go to the operating room before the doctor tries to intubate them. It can be that critical. So the worst thing we could do would be to try to examine the airway. And now we've closed the airway, and now we're trying to do a crike on the way to the hospital. So if you're ever considering those cases, just keep the patient calm and then just advise the staff of our suspicion when we arrive. So seizures. How do we treat seizures? What drug are we giving? So, right, so we're still giving Versed. When we look at the Versed dose through the protocol, it never changes. So whether you're giving it for seizure or sedation, for pacing or syncing, it's going to be the same across the board. So I gave my 5 milligrams, it didn't work. I repeated, I gave my other 5. I'm at my 10 milligram max. What would be my other option? The ketamine, exactly. So ketamine we're also using for seizures now. So make sure you realize that. Versed first, it doesn't work. Our next option would be ketamine, and we should be successful with the ketamine. Yes?
You said the Versed dose is the same throughout. Is the ketamine dose the same throughout?
No, and you'll see. If we're using ketamine for excited delirium or some agitated person, we're going to be giving it IM, but a higher dose. So yeah, that one unfortunately is different. Yes?
This morning we actually had a seizure patient that was allergic to Versed, so can we bypass that and just go straight to
Yes,
the
so
ketamine?
that, I was gonna say, so there are circumstances, and one would be, exactly, they're allergic to the Versed, that's why we have that option. Great question. All right, any other questions? Good. Okay, sepsis. So this is the patient we reasonably believe they have an infection. So normally we talk about they have a temperature, but technically the person could also be hypothermic. And we don't often think that, but that's true. So these are some of the ways you would reasonably think there was an infection. And now we come down, we know they're not pregnant, and now we're looking at our Q-SOFA criteria. So it's a little different criteria, but it's the same idea as our Sears criteria we used to use. We're using it as a predictor of who's a sepsis alert or in need of sepsis center. So if our patient has 2 of these 3 symptoms, so a hypotension, blood pressure less than 100, altered mental status, or tachypnea, so they're breathing fast. Why would a patient who's septic be breathing fast? What is their... Yeah, so that patient's in acidosis. So your body has a couple of different buffers to try to deal with the acidosis, the first being your respiratory. So you're going to start breathing a lot faster. When we start breathing faster, we blow off our CO2. So that's why we have in there. If your patient has a CO2 below 25, we're using that like the hospital uses lactates. So when you bring the patient into the hospital and you say, I think we have a sepsis alert, they're going to do some blood work, but they're going to do a lactate as soon as possible. If that's positive, meaning they're acidotic, they are now under that sepsis alert criteria, and that's when they very quickly do the blood cultures and they start the antibiotics. So we now know the sooner you get those antibiotics on board, the better the survival rate. So some systems are giving antibiotics in the field. We're not going to be doing that right now. Our key role is to identify these patients and get them to a hospital and call a sepsis alert. So we're using that CO2 as our lactate in the field, and we're finding there's a very high correlation between the two. So if your patient has 2 of those 3, the keys for us is to give fluid, notify the hospital, and try to maintain that blood pressure. So we talk about saying, all right, a sepsis alert. Apparently at some of the hospitals, they still don't fully understand what that means. But once the staff realizes they have a sepsis patient, they follow very strict core measures. And that, so what we're advocating, keep calling a sepsis alert, because we think eventually hospitals are actually going to be designated as sepsis centers. So let's keep doing that, and sooner than later it'll have a standardized criteria for it. So I give my fluid. When we have hypotension, how do we treat it now? We try our fluid. The fluid doesn't work, I go to my push dose epi. So you'll see that's the answer consistently through the protocol. It's a lot easier now. Any questions on that? Okay. All right, stroke. So we've been using the race scale. Broward County, specifically our department, has been very successful using the race scale. So whether you knew it or not, what you were doing was you were predicting whether you had a large vessel occlusion. So the higher the number, the more likely it was. And we're very good at calling that. So the hospital's telling us, good job, now we want you to think about it a little bit differently. So we already said we're only going to comprehensive centers. But as of today, do I need a race score of 1 or more to call a stroke alert? Yes. As of today, correct, Travis, you do. What if I suddenly had slurred speech? No other symptoms. Would I technically be a 1 on this race score? Well, if you read here, slurred speech doesn't count, so no, I wouldn't be. But if you reasonably suspect it was brain central etiology, so you reasonably believe it has something to do with the brain, possibly could be a stroke, they want us calling a stroke alert. And more importantly, going to a comprehensive center. So there's a couple more examples where that might make sense. So you don't have to have a race score of 1. Travis has an example the other day where the only symptom the patient had was they couldn't swallow. And they said, you know, call a stroke alert for that. So luckily, he went to the appropriate facility. So they're not saying we're not doing a good job. They're saying you're doing a great job. But we now want to make sure we don't miss any patient. So when they look at the admissions and the discharges, they try to identify all the cases that we missed, and not that we did anything wrong, but all the cases we missed that maybe could have been seen a little bit earlier. So that's what we're doing. Any questions on the stroke scale? It's still a 24-hour window, including wake-up strokes. This is numbers of the different interventionalists. A couple people were asking why FaceTime numbers. One of the Memorial docs, he actually has the crews FaceTime him with every patient, so he can actually see them. Our interventionalists are real happy with the way we're predicting and our accuracy, so we're not doing that right now, but that's a possibility in the future. So when we identify a stroke patient, we're going to the Comprehensive Stroke Center. We're going to still be transporting our patients at a 3rd-degree angle, and then if you notice, we're giving a fluid bolus. So not uncommon for stroke patients to have high blood pressure. 220 over 120. Why are we giving a fluid bolus? Correct, the circulation. So in the past, the patient had a high blood pressure. What was keeping the perfusion in the brain? That blood pressure. So we would lower the blood pressure thinking we were saving the patient, and we're actually making the stroke worse. What the patient's body was compensating, and particularly if you're older, you have collateral circulation in the brain. So what we're trying to do is we're giving a bolus, increasing the perfusion, hopefully creating an area that's survivable longer. So you remember when we talk about stroke, the penumbra, the area that's injury, if we can keep that viable, is the word they use, longer, we have a bigger window of success. So now when we bring these patients to the comprehensive stroke centers, a large proportion of them are actually walking out with no deficit at all. So the whole stroke procedure has drastically changed, even in the last 5 years. So this is one of the newer changes. So for some of us, it may seem a little weird because in the past we'd actually considered lowering the pressure, but we're pretty sure this is going to have a huge increase of patients walking out with no deficit. Pediatric, we said less than 18. They're going to go to a comprehensive center, Broward Health, Joe DiMaggio. Same idea, you're going to give the bolus. All right, so that's the end of the medical section. Okay, so now we're going to get into the cardiac emergencies. So when we talk about AFib, A-flutter, we used to have the conversation of, well, would we cardiovert them, new onset versus they've been in it a while? We're taking that away and we're saying we're not cardioverting AFib or A-flutter anymore. So our decision is the patient stable or unstable? And what we're asking is what their blood pressure is again. So if the patient has adequate blood pressure, what drug do we give for AFib, A-flutter? Cortisone. Right, still cortisone. So we're changing the dose a little bit, the way we're giving it, but still think we're giving it slowly. So 10 milligrams over 2 minutes. When would I stop giving the cortisone?
If you see a change?
See a change, and specifically look at the heart rate. So we wrote if the heart rate comes below 120, that would be an endpoint when to stop the cortisone. If it doesn't, then you would continue and give 15 milligrams over the 2 minutes. That should work. Now, while you're giving the cortisone, if the patient becomes hypotensive, you'd reasonably believe it was the cortisone that caused that. We would then give the 1 gram of calcium chloride and some fluid. Now, when we give the calcium, it'll actually help the blood pressure without taking away the positive effects of reducing the heart rate that we were looking for. So it actually works very well. Yes, sir.
With the saline, you got 1 liter form of saline. Are we doing 500 reassess and then
Yes.
or just continue?
Yes. So we'll actually make that read the same way. Yep. Yep. You always want to reassess periodically. We picked 500, but if for some reason you think it would be appropriate to assess sooner, absolutely. Yep. Okay, so if they are hypotensive, we would first want to get the blood pressure up a little bit, and we already said anytime we're dealing with hypotension, we're going to try our fluids if appropriate, and then give our push dose epi. Once the pressure comes up, then it would be appropriate to start the cardizem. So we definitely do not cardiovert. That would be our options of treatment. So if we're talking about bradycardia, we put a rate of 50. But if we have an elite athlete, we put the EKG on, they have a heart rate of 45, and they have nothing wrong with them. Are we concerned? No. So that would be our stable, we're not worried about that. We're talking about the patient that you put the EKG on and see 45 and you're very shocked by that. They don't feel well, they're diaphoretic, and you reasonably believe that that rhythm is causing the symptoms. So as a general rule, we're used to using the atropine. So we're going to continue using atropine. So we give some fluid. We talk about doing a 12 lead. So it's not uncommon if you have a hypotensive bradycardic patient that patient's having an inferior MI. That's why we're doing that, and we'll talk about that a little bit later. So we try our atropine. We're giving it in 0.5 milligram increments. If you see some effect, you could continue, but if you don't have any other effect, you don't have to go to the max dose. It would be appropriate to go to your push dose epi. So you would continue giving your push dose epi until the heart rate came up, but more specifically, your blood pressure comes up to an acceptable range. If these don't work, you could go to your pacing, or if there are circumstances, you'd go straight to pacing, like a high degree block, meaning a second degree, type 2, or third degree block. There's nothing saying you couldn't go straight to the pacing. If you want to consider sedation, as we said, our Versed dose doesn't change, it's the same. Now you notice for pacing, your heart rate now is 60. So there is some science behind that number, but if you start at 60, you get capture, and the blood pressure doesn't come up, there's nothing saying you couldn't increase the heart rate. So just keep in mind, it's not a hard, fast number. You are able to adjust it to titrate to the patient. Okay. So for bradycardia for kids, what is causing the bradycardia for kids? Respiratory, hypoxia, every time until proven otherwise. So when we talk about kids, we would try least invasive to most invasive. So we'd open the airway, we'd give a little oxygen. If that doesn't work, we consider putting an OPA and bagging the patient. Now we're ensuring there's adequate oxygenation. If that didn't work, that's when we would start our compressions. So now we're at our compressions. If we still have signs of poor perfusion, meaning delayed capillary refill, heart rate less than 60, we would consider, or we would go to our push dose epi. So this dose is slightly different than the dose we're normally used to on PALS. But we're confident it's going to work, so it's easier for people to think about, so we're going to try the push dose epi. So if you go classic PALS, it's slightly different, so just be aware of that. The unusual case that this didn't work, it is an option to pace the kids. Very unusual. Most people, we have a room of people in the class, most people have never paced a kid, never even seen someone pace. So this certainly would be the exception to the rule, but you notice the heart rate would be 80, and the same discussion applies. If you get capture, particularly if it's a younger kid, it would be appropriate to increase the rate if you thought that would help. Again, the Versed dose for the sedation across the whole protocol, even for the pediatric, it never changes. So once you learn it, it's going to be consistent across. So chest pain. So we show up to the house, the patient's complaining of chest pain. we do a 12 lead, and it talks about repeating the 12 leads. We need to get in the habit of repeating 12 leads. So we know just because you do one 12 lead and it's normal doesn't mean the person's not having an MI, particularly if they're symptomatic. So when we talk about someone being symptomatic, we're talking about chest pain, they're describing it as more of an area, they're complaining of nausea, maybe they're sweating. Those patients, we definitely need to do repeat EKGs. It is not uncommon to see the EKG changing. The hospital looks at our EKGs. When they do their new one, they look for differences. So it is definitely a value to us and the hospital when you get there. So we do my 12 lead, and later on you'll see verbiage of consider a 15 lead. So we're going to do training on 12 leads, and one of the components of that is a 15 lead. So the wording is we will do a 12 lead, consider a 15 lead. So when we're comfortable, we'll start implementing 15 leads, and that is looking for a posterior MI. So if we suspect an MI, the real teaching point is we're going to go to the appropriate facility, which would be what? A STEMI facility, right, exactly. So we're going to give our aspirin. So when we look at this treatment, if we said, what one drug do we know helps someone with chest pain? It's the aspirin. So we came with the dose of 324 milligrams. There's no specific reason of that dose. No one's decided this dose is absolutely the best dose. So don't read into the fact that we chose 324. But 4 baby aspirin, chewed up and swallowed, and now the next decision would be which drug do we give? Well, we only progress if the person's still having pain. And if they are, our goal is to get rid of that pain. So in the past, we used to think we're giving nitro, there was some benefit to the heart. It vasodilates, and we thought there was better outcomes down the road, lowering mortality. We're now pretty sure the nitro does not benefit the outcome and does not reduce mortality. So the way we want you to think about it is whether you're giving fentanyl or nitro, you're only giving it to get rid of pain, for pain reduction. That's it. So there may be situations, and the argument could be made that the better choice is fentanyl. So if you give fentanyl, you're giving it till you get the pain relief. If you choose nitro, same idea. So nitro may be given as a first-line drug. So you don't have to use one or the other. Is there any questions on that one? Yes?
It says if the patient was given aspirin within the last 24 hours, does it take into consideration any other blood thinners before you consider giving aspirin?
Good. So when we look, so in the past, we would consider, well, we're going to give it no matter what. If you reasonably think they did take it, you don't have to give the aspirin. Absolutely. You can believe that they took it. Yeah.
So it's not one or the other. You can do both. You're going to end up doing both, nitro and fentanyl. Or is it one or the other?
Typically, it's going to be one or the other. Do you have a specific?
No, if the patient's on Coumadin or something, you still give the aspirin.
No, but he's talking about just for the pain relief. If you gave nitro, could you give the fentanyl? Yes, but typically it's going to be one or the other.
One or the other usually.
But was your question, if you gave one, would that exclude the ability to give the other? Yeah, no. You could give the other one.
Ideally, the nitro is going to be the fast one we can get on board before we can get an IV access to give the fentanyl.
Good. So that could be a good reason to try the nitro.
You give 4 aspirin and a spray of nitro, and then you get a line you can switch to fentanyl.
Yes. Now, typically, the nitro, what's the contraindication? Low blood pressure. So if someone had low blood pressure, you may absolutely decide to go with the fentanyl. As we use this, we may decide to change it a little bit or say, you know what, this definitely works better. So all these protocols are new for us. So as we go along, we'll put out guidance periodically and try to help everyone make the best decisions. Okay, so STEMI. We said STEMI alert goes to a STEMI center, but we didn't specifically talk about what constitutes a STEMI alert. So there's a couple different things to really realize. So we talked about the 12 lead and later on doing the 15 lead, but what would constitute a STEMI alert. You have to have a basic understanding of 12 lead and the idea of what is an inferior MI, what is a septal anterior lateral. So when we talk about the 12 lead and we talk about 2-3 AVF, then V1, so the 2-3 AVF would be our inferior, V1, V2 is our septal, V3, V4 is our anterior, 5, 6 is lateral along with 1 AVL. If you have no idea what I just said, you need to refresh on the 12 lead, at least to be able to understand what the related leads means. So when we talk about whether we call a STEMI alert, we're talking about related leads, and that involves that discussion. So then we realize that there's a difference between a convex and a concave ST, elevation. So when we talk about elevation, we're actually looking at the J point. So when you look at a EKG, you have a Q, R, S, and where that line starts going straight again is where our J point is. And when we talk about elevation and depression, we talk about it from the J point perspective. So if you have an ST that is convex, meaning a frowny face in the picture, that's the worst case scenario. So that is not good. So in those cases, it only takes one small box of related leads to constitute a STEMI alert. So the only exception to that rule would be if it's V2 and V3, because those two naturally could have elevation. But if you don't even remember that, one box for the convex, call the STEMI alert. And always err on the side of calling it, particularly if the patient's symptomatic. The other way could be convex. So think of it like convex probably is not as serious, so it takes two small boxes to call the STEMI alert. And like I said, we're going to go into a lot more detail with 12 leads, but for right now, if you understand that, it's a good starting point to be able to call STEMI alerts with accuracy. All these definitions come straight out of the cardiology textbooks. So that's why we chose these parameters. You notice some of the mimics here. We're no longer calling new onset left bundle branch as a criteria, so we're only going to be using those other criteria. And when you read it, there's a lot of information in here, so when you have a chance to sit down and read it, I'm sure there'll be other questions, and Dr. Farrell will be available to answer them. All right, so CHF, pulmonary edema, fluid. So we said nitro wasn't that important on the chest pain for the physiology. Well, it is very important for the CHF. So when you look at CHF, what is it that's going to save our patient? The CPAP and the nitro. So we have in there aspirin. Well, why do we have aspirin in there? A high proportion of cases, a significant amount, the reason they have CHF is cardiac in nature. So that's why there's aspirin in there. So does that mean I walk into a house, there's our patient's full up and they can't breathe, and I'm saying, please take 4 aspirin, chew these up? Of course not. So we added language, you give the aspirin if they can tolerate it, and if you believe that it is cardiac in nature. So our priority is to get that CPAP and nitro on board. So the nitro will vasodilate and the CPAP will push the fluid out. So those are our priorities with CHF. Now you notice we took out all the different blood pressures. We used to say above 160, give a double tap, no max. We took all that out, and now we're doing 3 doses of the nitro again. So it makes it a little bit simpler for people to remember. So now we talk about cardiogenic shock. So by definition, the patient's blood pressure is low. So they may have fluid, they probably have fluid, but their pressure's low. So it talks about follow the CHF protocol. But if we go back and their pressure's low, we don't use CPAP and we don't use nitro. So how do we help our patient? Well, yeah, we talked about whenever you have low pressure, we're giving fluids if appropriate. Well, in this case, it wouldn't be appropriate because they already have fluid on the lungs. So our next option would be our push dose epi. So if you think about give the push dose epi, get the pressure up a little bit, and then use the CPAP. So don't split hairs on the blood pressure. If you feel comfortable, it would be appropriate to use the push dose epi while you're administering the epi. So that might be another case where you slightly deviate from the protocol, where technically maybe the pressure's a little low, but if you understand the mechanism and the physiology of what's going on, it'd be very appropriate to place the CPAP while you're raising the blood pressure with the push dose epi. If you don't feel comfortable, it would also be appropriate to raise the pressure first and then place the CPAP. Does that make sense?
The PEEP stays the same on the CPAP?
Yes, we're going to stay with 10. But now with the model we have now, we can adjust it. But yeah, for the CHF, we're going to stick with 10. Absolutely. Okay, so SVT, narrow QRS. And when we look at these rhythms, we're really asking ourselves, is my patient stable or unstable? If my answer is stable, I'm going to typically try a drug therapy or something less invasive like a vagal maneuver. There's a lot of discussion out there of which vagal maneuver is better. Right now, we're going to just say vagal maneuvers. We may get specific down the road of which ones we'd want you to try to use. So I do my 12 lead, 15 lead if appropriate, and now I decided my patient is stable, so I have time to try vagal maneuver. Hopefully it works. If not, I'm going to try to give my adenosine. So I'm going to go right to 12 milligrams. And what do I need to remember about adenosine? Right, the short half-life. So I want to make sure I have my flush readily available to push in, otherwise it's not going to work properly. So I try my adenosine and it doesn't work. So now I'm going to move on to giving cardizem. So we give cardizem for two reasons. One, it could break the SVT. But the second reason is if we were wrong and it was actually AFib or a flutter, it will work for that as well. So same discussion with the cardizem. We're going to give the 10 milligrams first over 10 minutes. If heart rate drops, we stop. If not, administer the 15 milligrams. And then if the pressure drops, we see the fluid and the calcium again. So that's the same idea as when we were talking about in the previous slide. If the patient's unstable, you could still try the adenosine because it's done quickly if they're alert, but your thinking would be, I need to use electricity or more specifically cardioversion for the patient. So you could consider sedating if you have time. And what joule setting am I cardioverting at?
360?
Yeah, that's not a typo. So we're going to start at 360. So all the cardiologists, well, most of the cardiologists agree cardioversion is very safe. The reason we might have been having issues in the past is we weren't using appropriate joule setting. So that's not a typo. We're going to start at 360 when we cardiovert. Okay.
WPW.
Thank you. So why do we have a picture of WPW there?
It's not everybody will EPA. Depending on the status of the patient, they can't tell you they have Wolff-Parkinson's white or maybe a family member or historian on it.
Good. So this gives you a fighting chance to be able to identify WPW. The vast majority of patients hopefully will tell you I have WPW. Why would we want to know that? Well, we would not want to give adenosine and we would not want to give cardizem to those patients. If you do, they have pathways, they have external pathways, and we could actually hurt or kill the patient by giving them those drugs. So we do not carry a medication to treat WPW. So if we did have that patient, what would be our options? Either just transport or we would then cardiovert. So we would not give adenosine or cardizem to a known WPW patient. Okay? Did you want to comment on that?
Just that it's called a bundle of Kent that they have, and you can see the delta wave on the EKG strip there. If the patient has its AV node blocked with adenosine or cardizem, then the current will go straight through the bundle of Kent, and it'll be an uncontrolled, rapid rhythm, and you won't be able to get the patient out of it. You'll probably kill them. So it's very important.
The 360 is multiple, like
360 more.
multiple times.
Yeah, we're going to actually, that was one of the things we're going to add that language of repeating it. And yeah. What we're told, most likely we're not going to have to. It's going to work. But we will add language just in case. So for the kids, make sure you remember the parameters for child 180 and infant 220. So those numbers are the numbers when you would reasonably think that that was the rhythm was the reason the symptoms were happening. Below that, maybe it was another issue, and maybe the rhythm was sinus tach. So same idea, stable vagal maneuver, drug, but if they become unstable, consider sedation and then the syncing. So our syncing, the Joule setting changed slightly. We were at 0.5 to 1. Now we're just saying 1, and then you can increase up to 2. Okay, so wide complex tachycardia. So wide complex tachycardia, we're talking about a QRS of greater than 0.12. That's only 3 boxes. That's not very wide. For kids, it's even less. It's 0.09. So in these cases, that's what we would start considering wide complex tachycardia. So if you notice, the rate is greater than 120. So before we were saying, well, what if you thought it was hyperkalemia? Well, we're describing a rate of 100 to 120. You have a wide QRS greater than 0.2. So that's greater than 5 boxes. It's going to look weird to you. The QT's wide. So we said you were all excited to wait for the slide of what you wouldn't give. So what drug would I not give if I suspect there was hyperkalemia? The amiodarone. You'll kill the patient if you give it to them. So that's one thing to look out for. And the key is how wide the QRS is and the rate. So the normal wide complex tachycardia will be above 120. And again, we're deciding, is the patient stable or unstable? I decide stable, I'm going to try my infusion of amiodarone, 150 milligrams, into a 50 bag, 1 drop a second using my 10 drop set, and I infuse it over the 10 minutes. Okay? If they become unstable, or you decide you want to try the syncing, the Versed dose does not change, and what is my Joule setting? Still the 360, right? So this talks about if you cardioverted them and you converted it, would you give the amiodarone drip? So now the verbiage is if it took 1 cardioversion, no. If it took 2 or more, you would give the drip. So the idea is you're trying not to give drugs needlessly, particularly ones with long half-lives like amiodarone. But if it takes more than 1 cardioversion, then we would give it. They need the antiarrhythmic. All right, any other questions on this protocol? There's a lot on that page, so obviously it's going to take time to digest it all. Okay, so polymorphic VTAC. So before we were talking about wide complex, we're talking about a monomorphic, or the waveform's all the same. Now we're describing a polymorphic where it changes. So the one we're most familiar with is the Torsades de Pointe. So a lot of the protocols will say try to sync, but be aware that sometimes you're unable to get capture and then you would defibrillate. We opted to go straight to defibrillation. So that is not a typo when you read defibrillation. But what would be the anticipated treatment for Torsades? Yes, still MAG. So always 2 grams, doesn't change. So we give our 2 grams of MAG over our 10 minutes. If they become unstable, that's when we can consider defibrillating them. All right, so that defibrillation is not a typo. Okay, so ventricular assisted device. We're used to it reading left ventricular device. They can be on the right side as well. That's why we took that language out. The key to this protocol is where would you take the patient? We have several patients in our city. If you ran that call, where would you go? My advice is that person is assigned a case manager. Call the number and follow their advice. If it is something to do with the LVAD or the VAD device, they need to go to a VAD center, Cleveland Clinic or Memorial. Right now, those are the only centers that install them. So, as Dr. Farrell has mentioned several times, Holy Cross, they don't install them. They don't have all the equipment. So if it is a problem with the VAD and you bring them to a facility that can't handle it, you risk that patient dying because we went to the wrong facility. It's a specific batteries, a specific equipment that they have to be able to treat these patients. So as of today, the only centers that we're comfortable to transport would be Cleveland Clinic or Memorial.
There's no helicopter landing facility.
Right. The other reason or the other consideration would be you would want to go somewhere that had a helipad to be able to transfer them as quickly as possible if needed. So that might arise if you're deciding, well, the problem's not with the device, it's a non-VAD related problem. Couldn't I go to anywhere? And the answer is yes. But if they're going to get admitted, they're going to have to get transferred because that facility isn't familiar, doesn't have the equipment with the VAD. But if you call the case manager, they'll walk us through the process. All right, any questions on the VAD? We're going to see this more and more. When they initially were putting them in, it was people waiting for heart transplants. Now they're using them for different reasons. So we're going to start seeing these more and more. And as things evolve, we'll change where we can go most likely, and we'll keep everyone updated. Okay, let's take a break, and then we're going to get into the cardiac section. So now we're going to talk about the cardiac arrest section. This is the one section that's going to be considerably different for us. We already talked that when we walk into a room, we got to make several decisions. So what is the first decision we're going to make?
If there's 7,
Yeah, whether we're going to work the code or not. So we're going to think of it a little different now. So in the past, we always talked about you need to have your 4 presumptive signs and 1 conclusive sign. Now we're going to think of it a little different. Once you have one of your conclusives, we're good. So that's not to say you can't include all your presumptives in the report still, but once we identify one of our conclusives, we're good. We can justify not working that patient. If the patient doesn't meet the conclusive criteria, that's when we would jump over to the other side. So when you're reading this, think about a patient with an unknown downtime, but we reasonably believe it's been more than 30 minutes with no CPR administered. The patient is asystole and has fixed dilated pupils. Those are the keys. We added apnea, but that's probably assumed, yeah. So the asystole, fixed dilated pupils is the key. And a downtime we reasonably believe is more than 30 minutes with no CPR. What is the survival chance for that patient? 0, exactly. So we realize that, we understand that, so now we're putting it in writing that we do not have to work that patient. If there is any doubt in your mind, you work that patient and you transport that patient. But this gives us the ability to call the patient without having one of those conclusive signs, because we know now there is no chance of survivability for the patient if they indeed have those parameters.
So that covers the gray area then?
Yes. That's really the intent of a lot of these protocols, was try to eliminate these gray areas and try to describe what we really do with good validation.
You have the no hypothermia, so you don't have to be cold.
Good point. So if there's hypothermia, we would still work the patient until there was no hypothermia. So down here, that's not the typical patient, but if you did find someone maybe in a freezer at one of the supermarkets, you would not use this, you would work the patient. Good, that's a good question. Yes, sir?
Known downtime, does that mean they haven't been seen in the last 30 minutes?
Could be. So that's a hard question to answer. But if you reasonably believe the person's been down with no CPR, and that's so, what does that mean?
If they're cold.
Yeah, so not the person that tells you, I promise you I was just talking to him 10 minutes. But it'd be more likely, yeah, I don't remember when I saw him. Yeah, it's been hours.
I came in the room and found them like
Right,
this.
exactly. So, if we decide to work the patient, so they didn't meet this criteria or we had any doubt in our mind, that's when we talked about, I'm deciding, is this a primary arrest or a secondary arrest? So we'll first talk about the adult, and we're assuming it's a primary arrest, so we'll go down the algorithm like that. Now just be aware, when you read, there's a lot of information in here. So there's no way you're going to be able to absorb all this right now. So I'm going to hit the high points. There are subtleties through here I won't talk about unless someone asks a specific question. So the intent right now is to get more of a general overview, and then we'll do more hands-on muscle memory training in the near future. So I have my adult algorithm. So does my patient have a pulse? If they do, our classic overdose scenario. We know how to do that very well. If they don't, I begin CPR. So it talks about a pulse compression rate of 220. So when you remember with ACLS, the rate is 100 to 120. So we easily could have put 200 to 240 compressions. They believe that the optimal number of compression rate is 110. That's where that number came from. We may change it to 2 minutes of CPR. So don't key in on that number specifically. What we're talking about is you're going to begin compressions for 2 minutes. During that time, we place our Lucas, we start our pit crew CPR. So everyone has our pre-assigned role. So when we walk into a code is not the time for John and I to have the discussion of who wants to do what. We've already decided that. That's the premise of pit crew CPR. We place our pads, we start analyzing and defibrillating appropriately. We work down our algorithm. We get a bag mask out, we ventilate our patients twice. We're really looking for, do I have a patent airway or not? If I don't, I go into my foreign body airway. So we're going to assume I have a patent airway. Now I'm down my algorithm and I'm deciding whether I have the primary or secondary arrest. So we're going to go down to primary first. So a lot of us have heard about this passive oxygenation, but we heard about it using a non-rebreather in the past. Well, we have our iGels. So the iGels we're very familiar with. So we're going to place our iGel instead of using our non-rebreather mask. So when we place the iGel, are we doing ventilations? We're not doing ventilations. We're hooking oxygen to our supplemental oxygen port. So you open your port, you hook oxygen to the port. Do we ventilate our patient? No. We're pretty sure positive pressure ventilations during this time actually decreases survival rates. Has to do with the thoracic pressure in the chest, the preload of the heart. So we're not ventilating our patients. Bless you. So it talks about 3 cycles of 220 compressions. So if you do 3 cycles of 2 minutes of CPR, how many minutes are we talking about? 6 minutes, exactly. So we continue this for 6 minutes, no ventilations, just using passive oxygenation through the supplemental port. After 6 minutes is when we would then start to ventilate asynchronized with our compressions, meaning we do not stop compressions. So how often would I ventilate my patient? Every 10 seconds, exactly, which went back to the front page when we talked about that. Yep. So if we decided it was a secondary arrest, the big difference is we would ventilate right from the get-go 1 breath every 10 seconds. So that's one consideration. The next consideration is what rhythm are they in. So if they're in PEA or asystole, we're going to use our epinephrine from the get-go. But you notice we're maxing our epinephrine at 3 milligrams. So we're pretty sure we don't have great outcomes when we use a lot of epinephrine during a code. We're still going to use it, but we're going to limit it to the 3 milligrams. If the patient presents in VFib or VTAC, we're not going to initially give our epinephrine. So if you think the patient's in VTAC, the heart's irritable, why are we giving a drug to make it more excitable to then give a drug to try to calm the heart down? It doesn't make sense. We're pretty sure that if you do use epinephrine during these cases, that you have worse neurologic outcomes if the patient survives. So we're going to not give the epi, but we would give the amiodarone during the beginning of the code. So we're going to continue this for 6 minutes. So 3 cycles. If after 3 cycles we don't get a pulse return, then we will use the epinephrine to try to get the pulse back. But again, you notice we limit it to 3 milligrams, so 3 cycles. So once you've given your max of amiodarone, your max of epinephrine, we're not giving drugs other than if you have an issue with the H's and T's.
And we've eliminated the bicarb.
So, but that would be part of the H's and T's. So absolutely appropriate, specifically if you believe there's some sort of acidosis, so you start using your capnography elevated. So all those things we've talked about with H's and T's in the past would still absolutely be appropriate to use bicarb. All right, any other questions on this? So again, there are some nuances in here that you'll notice when you sit down and really read it, and we'll go into further depth and actually do hands-on real soon. So if we go back and we talk about we're working the code, and we say at what point would we consider stopping or terminating the code? So this area talks about when that would be appropriate. So in the past, we would always have to get clearance from the hospital or medical direction. Now we're putting it into the hands of the officer in charge. So if you're working the code and you have a CO2 of less than 10, what's the problem?
Not adequate CPR.
Exactly. Your first inclination should be my CPR is not adequate. So either you need to switch someone out deeper, or the position of the Lucas isn't optimal. So you switch the position, you're pretty sure, or you're sure that your compressions are adequate. If you have persistent asystole, meaning more than 15 minutes, and the patient's CO2 is below 10, what are the chances of survival? 0. 0. We now know that. And the key to that is the CO2. We know anytime a patient has a CO2 below 10, 0% survivability. So if you've done all your ACLS interventions, so depending on the rhythm, the drugs have been given, you have an advanced airway in place, which would include an iGel, and you have this situation, we can call it without orders. Again, if there's any doubt in your mind, transport the patient. And probably we would transport, this would be the exception to the rule probably. All right, any questions on that? So when we talk about the pediatric, we already said it's a respiratory problem. So we're going to ventilate immediately, 1 breath every 6 seconds. But it still talks about withholding the epi for those 6 minutes. Now, when they did the study was actually done only on adults. But we reasonably believe that it will correlate to the pediatric, so we're going to try it. But just be aware, that's one of those cases where if we find that, you know what, maybe this isn't the greatest idea, we may go back. So, you know, I've said numerous times that these new protocols, if you enjoy EMS or into EMS, this is an exciting time. If you don't, this is the worst time ever, because we're going to constantly be tweaking and trying things. So these protocols, some of the things we're trying, they're absolutely based on evidence, but as you know, if you've been around a while, things seem to change, and sometimes we're tweaking things. So we're definitely going to start doing that with this. But with the studies that have been done, we already have really good ROSC rates. And more importantly, before we used to just look at getting a pulse back. So now we're pretty good at that. Now we're taking it one step further. We want people to walk out of the hospital and have some sort of quality of life. From what we know from the studies and other departments that are doing it, when we implement this, our ROSC and survival rates are going to go up even higher. So we're going to try it. We're relying on feedback from everyone, and then we'll adjust accordingly. So this talks about the CO2 level again. Talks about H's and T's. If anyone has a specific question, we can talk about it. Otherwise, I'm going to keep going. Some special considerations. We already talked about hyperkalemia. So the treatment we're familiar with. The excited delirium. high probability they're acidotic, so there's a great example. You absolutely would give your bicarb, cool them down. So you can read those. Does anyone have a specific question? We're good? Okay. The hypoglycemia. So why 250 in this case? There's no real rationale for the 250 D10 other than we didn't think it would be appropriate to say, okay, give 100, check the sugar, give 100, check the sugar. So we figured if the patient was hypoglycemic after 250, you definitely fix the problem. That was the only rationale. So don't read into that mLs. The CPR-induced consciousness. So I have not seen it, but apparently, particularly with the new Lucas devices, when we're doing CPR, we have patients waking up. And we think that they're waking up because they regained a pulse, but it's actually the CPR that's making them conscious again. As soon as we stop CPR, they lose consciousness and lose pulses again. So if you're faced with that scenario, that's a real scenario, remember that the treatment would be 100 milligrams of ketamine to sedate them a little bit so they wouldn't be discomfort and you could continue doing the compression. Right, that's why we switched on here. You'll notice some of the language and stuff is slightly different on here, and that's why I say even on this, the content, the ideas won't change. Maybe the language will change slightly, but the ideas will still be the same. We just want to make sure it reads as easy. That's why we're relying on feedback to make sure we eliminate all the questions. So when we talk about refractory VFib VTAC, it again talks about shocking, and this is where they talk in the county about the double sequential shocks where you put 2 sets of pads. Right now we're not doing it, but we may include it in the future. So that's where that spot would go. So we're gonna wait and see how it goes. So we may add it, we may not. So post-resuscitation, really, when you get the heart rate return, give the patient a chance to stabilize. And most of the time, the issue is with blood pressure. So we've already said several times, how do we increase blood pressure? We're going to give our fluids and our push dose epi. So again, you see, push dose epi repeats, very easy to administer. So we're hoping it takes a lot of the guesswork and anxiety out of any of the protocols. So you notice the ice pack. So why ice packs? Well, we're not trying to do hypothermia anymore. The only thing we know is that hyperthermia is not good. So if the patient has hyperthermia, you would definitely want to use some ice packs to bring them down to at least normal thermia. You could use the ice packs, and if we go to a facility and they start the ice, the cooling procedure, it's a good reminder for the facility to start that. So we're not doing that for the purpose of trying to go to hypothermia. The VFib VTAC, again, talks about if you convert them after 1 shock, you would not give the amiodarone infusion, but if it took 2 and more, you would. Same idea, that we're not going to give amiodarone if it's not needed.
And that's still even if you gave the pushes, right? Or are we still maxing?
No, that's saying you didn't give any. Okay. That's saying you hooked the patient up and shocked them right away. Right. So pediatrics, same idea, making sure we're oxygenating adequately, and then we're worrying about our blood pressure. Okay. Okay, now we're going to talk about overdoses. So anytime you have an overdose, we always will rely on poison control. They're amazing. They will walk us through step by step. They give us advice whether to transport, where to transport. They're the specialists. When you transport someone to the emergency room, they're calling poison control. So there's no reason we wouldn't take care or we wouldn't take advantage of the same expertise. So the number's the same, so make sure that's in the cell phones, your personal cell phone. They do an amazing job. So this just talks in general about overdose, but we'll talk specifically about each individual. So beta blocker, if you knew the name, you knew it was a beta blocker, the key to that overdose is the glucagon. Typically, they're going to be bradycardic. That's why the pacing and the Versed is in there. Now, the poison control will give you the dosing. It could realistically be up to 4 or 5 milligrams. So if the truck doesn't have that, depending on where you are, whether you call another truck or just transport, you would have to discuss that with poison control. Because typically none of us have 4 milligrams of glucagon. Very expensive drug, so I don't anticipate us carrying 4 on each unit just for this, because it's not that common. The calcium channel blocker, we already talked about it, to do with when we administer it, same idea. Your treatment would be the calcium chloride, fluid, and then again, if appropriate, pacing. Cocaine overdose, when we deal with these patients, they could have chest pain. We're given the Versed for the hyperactivity. It talks about the agitated patient. You notice we're using the ketamine for this. There's an IM dose and an IV dose. When we talk about the excited delirium, there is no IV dose. Why would that be? They're crazy. They're aggressive. There's no way we're expecting you to start an IV when the person's aggressive. So in that protocol, you'll see it's only IM. This one, there's an IV dose because it's reasonable that maybe you would be able to start an IV. In either case, there is a chance that the patient would have chest pain, particularly in cocaine. It can cause vasoconstriction. That's why you would follow the chest pain protocol, because that is not uncommon. Narcotic overdose, we left the range for the Narcan. So you can still give the 2 milligrams IM or give it incrementally. However, we've been doing it. We purposely left that window open. For the tricyclic overdose, the bicarb would be the key. Poison control could walk us through that, but it has to do with the pH level of the drug. When you become acidotic, the drug's free. We give bicarb, and that binds the drug. So it has to do with the bicarb changing the pH is why we're giving that. But again, poison control would walk us through if you weren't 100% familiar with what the drug was. Okay, now we're going to talk about chemical control. So when we talk about the physical restraints, as always, we got to be careful of how we're restraining our patients. We would never hogtie. We want to be able to justify what we did with the patients and utilize BSO when appropriate. If we're talking about chemical restraints, our primary drug would be our ketamine. So this is what we were talking about earlier, that we only have an IM dose. So you notice there's a dose range. On the next screen, we'll discuss a little bit why you might consider giving 200 milligrams. So whatever dose you decided to give, we wrote in there that you can repeat the dose of ketamine. So if your first dose didn't work, we want to make sure our crews are safe. You can administer a second dose. We're not concerned with ketamine of knocking out the respiratory drive. If we overshoot the dose a little bit and the patient's out, we can manage that. So we want to make sure the crews are safe. So we wrote it in so that you're very comfortable of repeating the dose if appropriate. So if the patient is older, they have head injury, a smaller patient, or you believe they have a benzo or alcohol on board, is when you would consider giving the 200 milligrams. But again, if it didn't work, you can repeat that dose. This patient, you would reasonably believe they would be acidotic. So again, why the bicarb and the cooling is all in there. Any questions on? Yes, sir.
More Benadryl for that?
For excited delirium?
Yeah.
No. No. Now the hypersalivation you see occasionally, and just like in organophosphate, the atropine would dry that up. But we wouldn't just prophylactically give Benadryl with this. Do you want to discuss that specifically?
Just very briefly, if you give the ketamine to the patient, you're not going to affect the respiratory drive. But the patient can have what's called an emergence phenomenon, So just tell the staff at the emergency department that you've given ketamine, you have not given a benzodiazepine. If you give those two together, ketamine and benzo, you can knock out their respiratory drive. So we've decided to just give one drug, ketamine, and let the people in the emergency department know that the patient can go through an emergency scenario. Okay?
But if you had success with Benadryl in the past, you're not allowed to use that anymore, is that what you're saying? Benadryl.
Benadryl.
Just, you mean just as a sedative? What Dr. Farrell was just talking about is one reason why some departments don't use it for pain for all people. So there are some issues when they come out of ketamine, and there's discussion on if we give it through an infusion or IV push. So that's another example that we may change slightly how we're administering the ketamine in certain circumstances. Okay, so pain management. If we had to say, what do we give for pain management? We're giving fentanyl. So the dose changed a little bit, but it's pretty consistent. So we would give our fentanyl, we can repeat it once, our max of 200 mics. If the patient's still in significant pain, that's when we consider going to our ketamine. But the ketamine we're giving for pain is very different than the dosing we're giving for the excited delirium. For pain, we're giving a dose of 25 milligrams. So right now, the way we're saying to give it is you're going to dilute your entire bottle of ketamine, all 5 mLs, into a 50 ml bag. So now I'm going to end up with a 10 milligram per ml concentration. And what's my dose I just said? 25 milligrams. So for my first dose, how many mLs am I going to pull out of my bag? Right, only 2.5 mLs. I can repeat it twice if they're still in pain. So the most I'm going to pull out of my bag is 7.5 mLs. That's it. The rest of the bag I'm going to dispose of. So just be aware, we're not dripping the whole bag into the patient. So very different. And again, we'll go over that. If you're using the IO, you notice we now have added lidocaine back into the protocol. Starting the IO is not the part that's the most painful for the patient. It's when we start administering fluids through it. So the 40 milligrams of lidocaine will numb the site and make it more bearable for the patient. So that's why we're adding the lidocaine back into the protocol. Okay, same idea with the pediatrics. The dose of fentanyl doesn't change. We use our pediatric tool to help us, and then ketamine's an option. Okay, this section for the advanced airway. As of today, we're not going to be getting RSI. We may use ketamine down the road to facilitate intubation. The few cases we had in the last couple of years, the problem was the patient had trismus. So ketamine wouldn't fix that anyway. In those cases, we were able to bag through that, and we had good success. So in a while, we haven't had a case where we'd have to use that RSI. So until we can train up a little bit, we're not going to use it right now. But we're keeping the protocol in for education and informational, and also so you have an idea of if we do call for the helicopter, this might be one reason why we call for the helicopter, and then you'd have an idea of what they would be doing to help us. Okay, environmental emergencies. We already said the decompression sickness, the key to that for us is transporting the patient to a hospital with a helipad. The drowning, so the patient survived. We would definitely have a high suspicion if there was fluid in the lungs. Doesn't mean they're going to have fluid just because the patient was drowning, but if you suspected they were, make sure you're considering using your CPAPs. Okay, heat emergency, we deal with every summer. We're good at that, so unless there's a specific question, I'm going to go through these slides a little bit quicker. Okay, bites and stings. We have the Xyrem spray. The Xyrem spray is working great. So if you don't have them on your truck, we have plenty in the pharmacy. Let us know and we'll make sure everyone has the Xyrem spray. But these protocols have stayed pretty consistent. Okay, carbon monoxide, again, the hospital with the helipad, and then they'll decide where the chamber is if it's appropriate. Who has the cyano kits? The battalions, right. So that's why we wrote in there, contact the battalion. Battalion 6-3 and Battalion 2-4 or 103 now has those kits. We each have one kit. Okay. Say again?
I was like only one.
Well, we have two. Typically one will work, maybe use another. If we need more than that, our neighboring cities, we know that we can call each other.
We've gotten away from that being primarily for us on a fire. It's just
Yeah, if you suspect it, yeah. So some cities and some hospitals don't have any. So it's not uncommon for the hospitals to get a case where they think it's a cyanide case, and they'll actually call us to transport it to the hospital. Again, they're inexpensive kits. All right, so we're going to take a break, and then we'll start talking about trauma. Okay. Okay, so now we're going to talk about trauma. The guidelines for trauma, they have changed a little bit. When we see the parameters for triaging, those are the same triage tools that we've been using. So START and JumpStart for the kids. So get familiar with those. Those are the same. What has changed is the cut sheet. So you'll notice they've added a few things for the level 2, and they've added blunt abdominal trauma for the pediatric. So what happens is the trauma committees meet, and if there are some injuries that are becoming common, and it would help including them on our sheet so we don't miss injuries, they update these sheets. That's how that works. So this is our summary sheet that we use on scene that we're used to. So just be aware that the latest one does have some subtle changes to it. The back sheets go into more detail explaining what the cut sheet means. So this information should coincide with the information on the cut sheet. There was a question on whether aspirin qualified as an antiplatelet. So hopefully this makes it clear. Should we consider aspirin an antiplatelet in terms of calling a trauma alert? No. So this makes it very clear. We do not include aspirin. So traumatic arrest, if you're not going to work someone, we're going to use this criteria. So if they're apneic, they're pulseless with asystole and fixed dilated pupils. So we added in injuries incompatible with life. So we're right by the train tracks. If someone stepped in front of the train and the head flew over the building and we got there quick enough and we put the limb leads on, could that person be in PEA? Yes. Would you work that? Obviously not. So that's why we added in the injuries incompatible with life, to just make sure we're answering as many questions, because that actual scenario we dealt with at one point. When you look at the penetrating injuries, it talks about how to control bleeding, clotting agents. We're gonna make sure all the units have the same clotting agents, and we're gonna get bags together so we have a unified system and materials to be able to deal with this. But when it's at a junctional trauma, meaning at your underarm, something that you couldn't use a tourniquet or put direct pressure, that's when it would be appropriate to use these things. The one change for us, if you have penetrating trauma, before you call the person, they want us to do bilateral chest decompression to rule out a tension pneumothorax. If you get a pulse return, we work the patient. If you don't, then you could say, okay, we're not going to work the patient. So that's a change for us as well. Burn injuries, same idea with the burn injuries. You may have seen some earlier versions of the protocol that didn't have burn gel. We are still using burn gels. We like burn gels, so we added them back in. So just to make it clear, we cleaned up the language a little bit. All right, this chapter, we try to take out all the questions. So do we have to use a backboard when we're transporting a patient with back pain? So we made it very clear, a backboard is not required. So when we use stabilization or cervical stabilization, we use the collar, and we're going to be getting the new X collars, which training's going to do with us very shortly. So we put the collar on. We can use a backboard or a scoop stretcher if we're using it to lift or move the patient to the stretcher. When the patient's on the stretcher, the backboard or scoop stretcher is to be removed. Is that clear? What we're trying to do is make it so you're very comfortable not using the backboards. So does that mean you can never use the backboard? No. The intent is to try to make you comfortable under the normal circumstances not using it. So if you're at sample and third and you use the backboard and you think you're going to use it to transfer the patient, you can leave them on it. That's not what we're talking about. But as a general rule, the backboard is not benefiting. In fact, we're pretty sure that using a backboard actually is worse for the patient. So when we can, we're actually going to go to scoop stretchers. Probably a better option. We do have to keep a couple of backboards for helicopter use. So we will have some, but we're going to go to scoop stretchers hopefully sooner than later. So the idea behind this was to make everyone feel comfortable. So the other day we had someone get hit by a vehicle and they were using the backboard as a huge splint for the patient. That's not what this is talking about. That's fine. Okay, any questions on that? Good. Head injuries talks about hyperventilating the patient, lowering the CO2. That's something we're familiar with. Hopefully will help with potential swelling. Eye injuries, we kept tetracaine. We're going to add 1 to 2 drops PRN. Some people aren't familiar with tetracaine. It's not a flush. You would just put 1 or 2 drops to numb the eye. So we're going to add some language in there to make sure it's clear. So chest trauma, we already talked about the needle decompression. Okay, so unless there's a question. Abdominal trauma. Okay, pelvic fractures. The key to pelvic, yes?
It says on this here, helmets should be removed on all patients, that motorcycle, football.
Okay, let's go back. What page was that,
That's
Larry?
new, I think. 111.
Yeah. So helmet should be removed. Doesn't say shall. So if you feel comfortable removing the helmet, you can remove the helmet and you would want to have access. If there's an airway issue, definitely remove the helmet. If for some reason you don't feel comfortable, you don't have the right tools, you think it'll be detrimental to the patient, then don't remove the helmet, as long as you're able to assess the patient and manage the airway if appropriate. Okay?
So we're not considering the helmet anymore. Like before, it was basically it kept a stable spine in some cases.
Yeah, if you decide in your professional opinion that patient's better off leaving it, it doesn't say you have to. Should, that language is specific because it allows for better assessment, but if you deem that it's better for the patient to leave it on, you can leave it on. Yes, sir.
The new X collars hold the head and the shoulders. They do not touch the neck. So these old C collars that old people are complaining about, feeling choking sensation with the collar wrapped around the neck, that won't exist anymore. The X collars have a large area in the front in case you have to do cricothyroidotomy or something. But these are a great improvement on C collars. So we'll get the training done as soon as possible. You better use those. Okay, any questions on that? Okay, good.
Okay, where were we before Larry?
Chest.
Hip fractures.
117.
Hip fractures. Okay. So hip fractures, the key is to try to stabilize the hip, minimize any bleeding. So some of the agencies are using something called a T-pod. Right now, we're just using a sheet. We may adopt something else, but the idea is to stabilize the hip. Scoop stretchers and a sheet work very well. Femur, we're actually pretty good. We've seen a couple cases. If there's hip involvement, You may not want to use the splint, but we can talk about that when we do the training with the collars and everything. Okay, this talks about tourniquets, stop the bleeding. There's a whole presentation we're going to do sooner than later, so we're going to move over this unless someone has a specific question. Okay, trauma and pregnancy. The key was where you're going to go. We already answered those questions, so you'd refer back to that section. Trauma resuscitation. So if you have someone who's bleeding out, we now will have the option of calling the helicopter for blood. So we now know that whole blood is the best option for the patient. They will be carrying whole blood. Sooner than later, we may start carrying plasma, but right now we're not, so we're still going to be doing our saline and transporting to the hospital.
So if we call BSO out for blood, then are we relinquishing transport to them?
Probably, but they'll go over that when they come talk to us. If we want to call them merely for the blood, they're willing to do that too.
And then we transport ourselves.
Yep, so we'll have to ask all those questions when they come out.
But I think with the blood itself, that they would want to, because of the fact they're supplying us, it's almost just like supplying with a drug.
Yeah, I'm guessing they're going to want to take the patient, because when they administer the blood, they actually use a specialized pump, now that you're saying that, and they have warmers and stuff, so I'm sure they would either come with us if that was more appropriate, or we'd turn the patient over to them. Yeah. Okay, same idea, just the fluid. So neurogenic shock, so the patient has an injury. Below that level, the body's not able to vasoconstrict, so the end result is the hypotension. So again, we're using our fluid and our push dose epi. Okay. Okay, this we left in there again for informational. So if we did call them for the blood products, we at least have an idea of what we would expect them to be doing. But we are not carrying blood anytime soon. Okay, OB. These did not change except for the eclampsia. So I'll go through these slides slowly. If someone has a specific question, we'll talk about it. Okay, ectopic. So eclampsia. So what's the difference between preeclampsia and eclampsia?
Blood pressure.
The seizure, more specifically. But both might have significant hypertension. So if the patient has the hypertension, the altered mental status, the headaches, visual disturbance, so basically they're symptomatic, we're going to treat them. So if we're treating them, how much MAG are we giving them? We said it's always 2 grams IV, but we're going to give 4, but the other 2 we're going to give IM. So we're going to try that and see how that works.
We still treating postpartum 6 weeks?
So can someone be eclamptic postpartum, meaning after they gave birth? Absolutely. Up to 6 weeks. So absolutely could happen. Yep.
Wait, so we're giving our initial 4 in a bag, and then we're giving the second dose?
So what we're trying to do is make it easier for people to remember. So the MAG infusion, no matter what protocol you use, would always be 2 grams. Because eclampsia, 4 grams is the desired goal, we're going to give another 2 IM at the same time. So you would hang the drip and give them 2 grams IM. Okay, no questions, we'll keep going. So normal delivery. When you look at this, this is NRP. This is a whole class in itself. So obviously we don't have time to go into this. We're going to get specific training on this, but just be aware when you talk about the respiratory, whether you're going to bag it, revolves around a heart rate of 100. If you're going to give compressions, it revolves around a heart rate of 60. And if you decide to give compressions, it's at a 3-to-1 ratio, ventilating 40 times a minute. So this is the proper way to do CPR or resuscitate a newborn. So this is NRP, and we'll do more training before we implement the protocols. Okay, cord, prolapse. All right, this last section, again, talks about the drug. So on page 10, it talked about this, and we have it back here so that if you're going to go to the pediatric medication tool, it's here all in one spot. So it talks about the same drugs that we talked about on page 10. This is the pediatric medication tool. So just be aware when you're using this tool, make sure you're using the right drug, the appropriate drug, and you realize the dose, but very important is the concentration. Right now, we have the same concentration of drugs that they're using on this tool. But with the drug shortages we've been experiencing periodically, you have to realize if we end up not having the right concentration, because this tool would not work. You'd have to adjust the doses accordingly. So just make sure, it's very important to realize what concentration you're using.
So the Versed, because I remember you mentioned that about the Versed.
Yeah, so Versed, we're back on the same page.
Okay.
Yeah, the only one that currently we have an issue with is ketamine. This talks about 100 milligrams per milliliter. We have 50, but by the time we go live with this, we'll have the right one. Yep. So we should have no conflict to this protocol when we're ready. And be aware, certain drugs, it depends if you're diluting them or not. So a good example is Benadryl or diphenhydramine. One route we dilute, one route we do not. So make sure you identify which route you're going with. Okay, same tool but different medications. And this talks about the medications and the doses. So that's exactly what you were asking. This tells you exactly what concentrations that tool deals with. And again, these are the ones highlighting which ones need to be diluted. Okay, pit crew, we're very familiar with pit crew. The whole idea is everyone has a job, we work efficiently. Any questions on pit crew? This highlights the changes from the last version. This being very new for us, this isn't as appropriate for us as in just read it all, take your time, write down your questions, and if I can't answer it, we will definitely get an answer from Dr. Farrell. We want to make sure everyone's comfortable. The whole goal of this is to make a protocol that takes as much of the guesswork out of it as possible. So in the future, when we would have to go to committees to make changes, we can make the changes on this. So please give your suggestions because we will take them into consideration. We can't change everything, but if it makes sense, we can very easily make the changes. All right, does anyone have any questions? Okay, that's the end of the changes. Thank you very much for coming, and we look forward to continuing the training soon. Thank you.